Hello, everyone, and welcome to the Nurse Linda webinar. This is my favorite day of the month when we get to spend this time together, and we have a load of questions, so I am just going to jump right into it. So, our first question is from a lady. She's 5 years out in her spinal cord injury, and she's hoping to get information on activity-based therapy and closest locations, but I don't know where she is. So we'll just talk about it in general. So activity-based therapy, activity-based rehabilitation is a program where activity is used to stimulate the nerves and muscles of the body, especially below the level of spinal cord injury for recovery. And there's a lot of different offshoots of this. There's a lot of different interpretations of this, but it's a very specific program of therapy. And so I'm not sure where you are from, but there are some places, Project Walk in California, and I want to say they have a location in Texas. I don't know why I'm thinking of Texas, but Project Walk is one. The Kennedy Krieger Institute in Baltimore is one. So you could go to those facilities or look them up online and see if that's what you're interested in. But most people need to stay close to home, and you might not live close to one of those places. Those are also places that will accept insurance coverage or Medicaid if you live in the state where that is offered. However, that's only for a limited time, and then the recipient of the therapy, the patient, is expected to pay the cost of that. So it can become quite an expensive endeavor, but it's still very beneficial to some people. It's probably the best thing to do is to talk to your spinal cord injury specialist, tell them what you're interested in, the specific kind of therapy, and then talk to them, because your spinal cord injury physiatrist will know where the closest place is to you that would be the best place for you to go in your individual needs. So not everybody qualifies for all these kinds of therapies. So it's good to have somebody who's helping direct you. Now, if you don't have a place that's close to you, for instance, there is a place in Minneapolis where a gentleman who had a spinal cord injury started his own activity-based recovery gym, and there's a fee for going to that, but they also have scholarships for it. So, but these programs are so isolated around the country. There's not really a place where you can look in a book and look online. You could type in activity-based rehabilitation. You could just type that in Google and put near me and see if you can find one in that way. The Reeve Foundation has a neuro recovery network, which has a lot of information about different elements of this kind of program that there might be a place close to you. If you can't find something that's local to you, if you live near an academic medical center with a rehabilitation program with a spinal cord injury specialist, they will have one. Now, again, this comes down to an insurance issue, because, just because you say, I'd like to go to one, and just because it might be the best thing on earth for you, does not mean that insurance is going to pay for it. So a technique that you can use, and it's a little strategy, is to talk to your rehabilitation specialist. And just about every rehabilitation healthcare policy, if it's private pay or if it's Medicaid, allows 2 weeks of rehabilitation for mobility training. And you could put this under mobility training. It doesn't have to be 2 weeks, Monday through Friday. It could be like every Monday for 14 Mondays, or every other Monday. So, you can arrange it however would be necessary, and also within your care needs. Maybe going every day for 2 weeks would just be overloading your system, and you really wouldn't get the effects of it. Maybe you need to go one day, have a day of rest, and then go another day, or maybe just go one time a week and get that evidence that this program's working for you. Because when your healthcare professional writes that letter of medical necessity that says that you need this program, they can say, look, she did this for 2 weeks, and these were the results that we had. And maybe you'll find that you do it for a couple of weeks and it's not going very well, but your body responded well to it. So there's all kinds of things. So working with that healthcare professional to write that letter of medical necessity, and they kind of know the wording. There's kind of like a different language. It's all English. But when you write these letters of medical necessity, you have to know what to put in there, what's important and what's not important for the insurance company to know. And by not important, I don't mean like, well, it didn't go well. And so, why do this thing anymore? But it's kind of like somebody might say, well, it helped, I don't know, it had some kind of effect on me, and the insurance company's like, yeah, well, we don't care about that. But if it helps you mentally, if it helps you physically, all those kinds of things are important. So if you don't live near a large medical center that you can find this kind of treatment, sometimes local hospitals will coincidentally have somebody who has worked in a spinal cord injury specialty facility, and so they'll be familiar with it. Sometimes you can find a healthcare professional in your area that's just really interested in helping you, and they will do the legwork on helping you find what therapies to have, how to get involved in these therapies. uh, Shepherd Center, Craig Hospital, Baylor Rehab, Shirley Ryan, University of Washington. If you live, if you don't even live close to these places, your spinal cord injury professional can contact the physicians in these high level rehabilitation specialty hospitals and get the information that is needed to craft a program that would be specifically for you. So don't count yourself out if there's not any place close. It's just kind of finding the right person who's willing to help you work with these kinds of things. So that's going to be a real possibility for you, and I hope that that all works out. Now we have another question from somebody who had a spinal stroke. So a stroke in the spinal cord, and a lot of people don't realize you can have a stroke in the brain, but the spinal cord is part of the central nervous system, so you can have a stroke in your spinal cord as well, and that's what has happened to this person. They were initially paralyzed from the waist down, and they went to Kessler, and so that's also an excellent place for spinal cord injury, and the results were limited. And I like to say they didn't ask this in their question, but the results were limited, I would say, at this time, because even though you complete rehabilitation, that does not mean your recovery time is over. That just means that this was the amount of time that you were allotted for this, or you were making really quick progress and then it slowed down a bit, but you can still do a lot of things at home and continue your rehabilitation. It doesn't have to be in the rehabilitation center. Generally, when you're discharged from places like these specialty centers, they'll give you a home program for things that you should be doing at home to continue your therapy. And so he has some limited walking, so you want to keep up with that. And he's walking with a walker with PT and OT. So, and he's taking outpatients. So keep up with that. Notice the particulars of everything they do. Ask if there are things that you can do at home to help increase your productivity in your therapy sessions. And then rehabilitation really goes on through the lifetime, but sometimes you're not getting it from a therapist. So learn everything you can about what they're doing, how they're moving you. Have a family member or learn to move your body in the same way that they're moving you, because you don't want to stop. Your nervous system is not ever going to stop trying to recover. Usually, the old way of thinking was that after 2 years of a spinal cord injury or a brain injury, that was it. You're not going to have any more recovery. This is not true. People have recovery for the rest of their life as long as they keep doing their therapy, keep moving, keep their body active. If you're just sitting and being static and not moving the parts of your body that don't move, they're not getting that stimulation that's helping them recover. So keep on with your therapy. Eventually, it's going to translate to more management on yourself on your own. But remember, you also have that 2 weeks of mobility training in your insurance coverage. And so every 2 weeks of the year, don't let that lapse. Every 2 weeks, everybody should be going. Every year, everybody should be going for 2 weeks of more rehabilitation therapy. You might want to switch over if after you get discharged from the therapist, you might want to try aquatic therapy. You might learn about aquatic therapy at your outpatient, and then you might be able to do it in the community. So if you go to Wise, usually have heated pools. If you check on your, again, Google heated pool near me, public heated pool. So if you can go with somebody, they can help you learn to do your therapy and do some aquatic therapy. So there's all kinds of things that you can do on your own, but sometimes people think, oh no, I have to be with the physical therapist, or I can only do it in this facility. No, you keep doing all this stuff, but eventually they will transition you into doing more of these things on your own. So you're making good recovery now, and there's every reason you will continue to recover. So don't listen to anybody that, oh no, you've got 2 years and then it's over for you, because that is just not true. You'll keep recovering. We have someone else who's, oh, now I get a lot of questions like this, variations, a lot of these questions. So I'm going to talk about this one a little bit longer. But here's an individual, and they were on Medicaid, but they're no longer on Medicaid, and they only have Medicare. So they want to know, how do you get home supplies? Well, Medicare will supply those for you. Now, the cost that you have to pay may be different. And every state is different. Medicare is run by the federal government. Medicaid is run by your individual state, and each state's program is a little bit different. So what was paid for by your state's Medicaid may not be paid by another state's Medicaid. So it's because that's specific to where you live. But Medicare is federally funded, and there is a book, and it's called My Medicare, and it comes out every year. I get one mailed to my house because my husband had uh, had used that service from the government, and so it comes to your home, or you can just look it up online. But every year, the parameters of what Medicare pays is different. And so you can look up My Medicare 2024 on the computer, and there will be that booklet, and you can just go through it right at your home computer. You can also get a hard copy when you're on Medicare, one gets sent to your home. So you know exactly what they're going to pay and what they're not going to pay, and how that all will work. So your doctor will now send the order for your supplies to the Medicare company, as opposed to the Medicaid people. But what you're going to notice is that there's going to be a difference in cost, and there might be a difference in the products. So the state Medicaid may be paid for one brand of catheter, but the Medicare is going to pay for a different brand of catheter. So you might notice a difference in suppliers, but the product will still be what you need. So that will be good. So how do you get services with just Medicare? Again, your physician sends a prescription to the Medicare office, and so you will know if that will be paid or not if you can look in that Medicare book, and it will tell you just what is covered and what is not. And then the question is, what will cover for wheelchair maintenance and more? And that all depends on, usually the maintenance goes with the company that supplies the wheelchair. So both Medicaid and Medicare have restrictions. Pardon me one moment, I just need to take a little sip. Sorry about that.
I put the link for the handbook in the chat for you.
Oh, great, thank you. Look at Zach has it in the, see, it takes a cadre of people to run these sessions. But the link right to that Medicare.gov book is right there. And so usually servicing the wheelchair goes through the distributor of the wheelchair. So whoever supplies that wheelchair, that is usually covered by them. Now, both Medicaid and Medicare have limitations on how often you can get a new wheelchair. If parts are broken, sometimes they depending on the situation, sometimes they will pay for new parts, sometimes you have to pay for those on your own. It's all on an individual kind of relationship, but the general rules for what happens with what's covered by Medicare will all be in this book, and it's all perfectly clear. So you will know what will be your responsibility and what will their responsibility be. So that kind of makes it very clear. That's the same way private insurance works. So if you had a private insurance policy for other listeners and you want to know what's covered, you have to look that policy by number up on the computer, and there will be all the specifications outlaid with, what they cover, what they don't cover, and how it all works. So all of that is information that is provided for you. Now, in private insurance, you have to know your policy number, and you can get that off your card, because a private insurer might have, I don't know, 100 different policies, maybe more. Maybe they have 1,000 different policies. I don't know, but each policy is different. So if you just look up, say, Blue Cross Blue Shield, will you cover my wheelchair? Well, it depends on what policy you bought, depends on how they cover your needs. So it depends on what you have purchased from that company. Okay, um, here's an individual with who's incomplete paralysis and a left arm nerve avulsion from a motorcycle 3 years ago. And so what they're looking for, um, is they're looking for any recovery now that it's 3 years. Yes, the it's incomplete injury, and so there is always, the nervous system is always recovering. Now we know a lot with these electrical stimulation therapies that are out, and even more coming out. So this is a boom time for recovery in spinal cord injury and brain injury. And so we know that functional electrical stimulation helps people recover. Now, some more than others. And in particular, we know that people who have incomplete injury respond at a greater rate than those who have complete injuries. Now, it's not that complete injuries don't recover, it's just that we see more recovery with people who have incomplete injuries. So that would be an opportunity to talk to the healthcare professional about getting into some of these advanced rehab programs, trying some of the e-stim to see if that's helping. Now, there's also a question about the left arm, and it's a nerve root avulsion. Now, this one is a little bit of a trickier situation. If the nerve root avulsion is on the outside of the nerve root, out in the peripheral nervous system, there are all kinds of things, surgeries that can be done to help improve that, so they can move nerves around, they can move muscles around, they can move tendons around, and you can get function back in that arm. If it's inside the spinal cord injury, you cannot do those surgeries, but they can do other ancillary types of surgeries where they might take a nerve to graft over where that nerve that's not working, and gives a little more recovery. Now, there's a lot more success with these surgeries if it's done within 6 months of the injury. So that doesn't mean you won't have success, but you might not have as good of success as if it was done earlier. But we don't know that. You might have even better success now that it's been a while and maybe he's built up his muscles. So, it's just a good idea to talk to somebody about these things, because there are treatment for avulsion injuries that can help his left arms. And there are treatments for people with incomplete injuries and with complete injuries that are making really fantastic kinds of recoveries. It's not the recovery in incomplete, he could become fully recovered. In complete injuries, people do have recovery from complete injuries. More than likely, people have some recovery, but it continues on. But sometimes after, like if you have a broken leg and they set your broken leg and it works just fine, but it's not wide as it was before it was broken. And so sometimes whenever you have an injury of anything, you can have a very satisfactory life and recovery and repair, but maybe it's just not quite as it was before. So, you have to think it's not like somebody's going to do a surgery and tomorrow you're going to be all better. It's going to be the kind of thing where you might need surgery, you might have to have therapy that goes with it. You might have to try some of these other advanced treatments. You might have a plateau for a while and then, you think, okay, well, this is it for me, but you keep doing it. And then all of a sudden, you have a little more improvement. So this is rehabilitation is an ongoing, lifelong kind of recovery process. And sometimes it comes quicker, sometimes it goes more slow. We'll find some questions from people who were injured a long time ago, and they were going along through life just fine, but aging caught up with them, and suddenly they're not moving as well as they used to. We see that a lot in the post polio, where people recovered from their polio, but they didn't realize that it wasn't all of their muscles recovered, but muscles that worked compensated. And then when you get older, you kind of maybe lose a little muscle tone. And so all of a sudden it's not working like it used to. So, it's an ongoing process. Let's just put it that way. But it is possible and you will continue to get better. And that's the message that I hope that everybody hears. But it's a lot of work. So here's a gentleman that has a T4 trauma 3 weeks ago. So this is a really fresh injury. And his blood pressure keeps dropping during rehabilitation to very low levels. He's taking medication for these. And so she has some questions about it. Well, let's go through the hierarchy of treatment. So there's things that we do first, there's things that we do second. So this is a very common thing to have low blood pressure after a spinal cord injury. It can happen after a head injury where you have a difficult time getting into an elevated, a seated or standing position. And so it's called orthostatic hypotension, which means low blood pressure when your head gets higher than your heart. That's what it comes down to. And so what we'll start out doing, and this is so common with people who are just newly injured. And so the first level of treatment is they'll put on those elastic stockings. They're called TED hose. And they'll put them, they're specially measured to your legs and they'll go from your toes all the way up to your thighs. And the reason why we use that is because after the spinal cord injury, the body has lost that communication from the brain that says, oh, you're setting up, constrict your vessels so that the blood flows more up to your heart. And this is the way the body works for everybody. So if the leg muscles can't contract to make that blood flow up to the heart, we put on these stockings that gives a little elasticity to the legs so the blood doesn't pool down in the legs, but it pushes up to the brain. So that's the first thing we do. If that is not enough, then we'll get an abdominal binder that people wear around their abdomen because sometimes there's a lot of blood vessels that go to your stomach, to your bowel. There's a lot of blood vessels in your abdomen. And so they'll put an abdominal binder on to help that blood push up again. And so, again, that's what we're trying to do. If there's still problems after that, we'll put elastic ace wraps on top of the TED hose on the legs, further tightening those vessels in the legs, tightening those muscles to push that blood up to the head. Medication is now the next choice, which he's on that medication. The question she has, would increasing fluids before trying to get up help? Well, yes and no. This is a very cautious area. So, when people think, well, should we hydrate before that? Well, you have to be careful about the bladder management program, number one. So, you can't take in a large bolus of water when you're on intermittent catheterization. And so that, would have complications with your bladder, which leads to complication with the kidneys. So you can't have that. So what people will do is if they can hydrate, what they'll do is they'll start an IV because that's just a little drip, drip, drip. It's not like taking in a whole glass of water right before. So it absorbs into the body more quickly, and it doesn't just settle like a big pouch in your stomach. You know, if you take a lot of fluid in, your stomach's going to fill up. The blood is going to go to your stomach as part of the digestion process, again, robbing it from the heart. Now, these are all like minuscule little amounts. It's not like the blood's not going to your heart because now it's going to your stomach, but there's a little bit of shift of blood that's going to go to your heart, and that little bit, or to the stomach, and that little bit of shift, we want to keep the blood circulating in the heart. So we have to be real careful with big boluses of fluid before, for a variety of health reasons, before doing that. So sometimes that the next level would be to start an IV a couple of hours before he does that, to have that slow little drip going into his body to hydrate it well. And then another question would be, would leg exercises, moving his legs, help before he tries to sit up? Well, it can help, but it's probably not going to be enough to get that circulation going, because what we're looking for is the contraction in the leg muscles. It's going to move the circulation, but it might not be enough. It's usually the TED hose, the abdominal binder, the ACE wraps, medications, IV drip. That's usually the way the treatment goes. Would moving the legs before he does his therapy help? I don't know that it would help that much, but it does not hurt. So it's always good to keep those legs moving as much as you can if there's not a blood clot involved. So that's important too. So for every treatment we have, there's always things we have to be careful about. And so I try to tell you all of those things. Some people can take up to 6 months sometimes to get their blood pressure adjusted to sitting, and that really messes up the rehabilitation process, because you either have to go home and get adapted to sitting at home, or you have to go to another facility, long-term care, because if they can't participate in therapy, they can't stay in the rehab hospital. So that's a payer issue. So it can become quite complicated. They will also try sitting him up using a tilt table. So you lay flat on the table, and the tilt table just slowly, they'll move it up 10 degrees. If that's tolerated, they move it up a little more and a little more, taking the blood pressure the whole entire time while they're doing that. So that if they can get him up 10 degrees, they'll do the therapy with him at that angle. If they can get him up to 20 degrees, they'll do it at that angle, and they keep working with that while they're doing the other therapy. So they try to combine that all together so you get the maximum treatment out of your time. So that's the process with that. But I love the thought that you're thinking ahead, you're thinking about things, and you're asking too, would this work or would this not? So that's really critical. You're going to be a valuable wife to this husband as in his time of recovery. So a real advocate for the patient, and that's huge. Any new information on the management of neurogenic bowel and bladder? There's a lot going on in both of these areas, and if you've listened before, you know I can talk about neurogenic bowel, bladder, and skincare for days on end. So I always delight in these questions. So there's a lot that's going on. There's a lot of improvement in bowel and bladder function with these FES devices. That's a big offset of that. People who do the FES biking, the functional electrical biking, have less bladder infections, and they have quicker bowel movements because you're stimulating the abdomen where the bladder and the bowel are. So that is treatments that are coming, and FES is developing in a rapid pace right now. And so there's a lot of good things that are coming out of the FES scientific world. Another thing that for neurogenic and bowel and bladder is that there is some implants that can help neurogenic bowel and bladder to help stimulate the evacuation processes on both points. So those are surgical procedures, but there are different things that are being done. And so, again, some nerve grafting and moving things around. And so, these are things that are available now, but you have to find a specialty person that does this in a specialty center. So those are some things that will be coming more to market soon. And I mean like within this year. So those are things to watch. Now I notice on neurogenic bowel, there's a couple of things that people do in their bowel program, and I don't think that a lot of people are taught these things, perhaps. I don't know, but people tend not to do it. As I say with bowel program, I always say, I have yet to meet the patient that's, says, "Oh gosh, now that you've explained the bowel program to me, I'm delighted. I've been waiting to do this my whole life." Nobody's eager to do a bowel program. And so, but what I do notice is that there's a couple of things that people do. Number one is if you put in a suppository or if you use one of the mini enemas, you should never use a large size regular enema. It has to be a special mini enema. Enemies makes one. But if you put that in your bowel to stimulate your bowel to work and you put it in the center of stool, neither of them work. You've got to put it up against the bowel wall because the suppository will not dissolve if it's in stool because it takes the heat of the body next to the bowel wall to dissolve this suppository to stimulate the bowel to activate peristalsis. The same goes with the mini enema. You have to put it up against the bowel wall to stimulate the nerves to work. So sometimes you have to manually remove if there's stool in the rectal vault. That's what we call it. You have to manually remove that so you can get the suppository in so that you can bring down the rest of the stool to get it out. So that's very important. Another thing is that people will put on their glove and they'll get the lubricant ready on their finger and they'll put a little teeny tiny drop of lubricant on the tip of their finger, and you're like, that's not enough lubricant. The bowel tissue is very delicate, and when that glove rubs up against the inside of the bowel, if it's not lubricated, it's going to cause friction, which is going to make hemorrhoids. It's going to make fistulas. It's going to put sores in your bowel. So be sure you lubricate your finger well before insertion. Now, I know that lubricant is drippy, it gets all over, but be sure you've lubricated well. That is a critical importance to the bowel program. And then also, the other thing is on the digital stimulation is that people get in there and they want to whip around that finger because they want to get in and they want to get out, and they are very aggressive and they do it as fast as they can. And that is tightening the inner sphincter. So it is clamped tight, and that stool is not going to come out until that inner sphincter relaxes. So you have to do it slow, easy, and gently. You're relaxing the inner sphincter. So fast and aggressive is making your bowel program much longer. Slower is making your bowel program much faster. So that's just a good rule to follow. Now on the bladder, we were talking about some of the bladder things before. There's a lot of things coming down the pike. There's a lot of alternatives to bladder. If you are a woman and you find you can't position yourself to catheterize, there's the Mitrofanoff, which makes a little hole through the belly button. And you put your catheter in there so you don't have to even get out of your wheelchair to do that. Some men elect to have that as well, depending on what their situation is. So there's just a lot that's coming out on those kind of things, and we have to stay tuned for when those become available to the public. The next question is about a lady who is postmenopausal, and she's having periodic sweats and high blood pressure spikes, and it seems like it's autonomic dysreflexia. And what can be done to find a cause? Well, first of all, you have to know if it is autonomic dysreflexia. So you have to take the blood pressure. You're having blood pressure spikes. So you have to take the blood pressure to see if it is autonomic dysreflexia. And that's elevation of the blood pressure. So you have to know what the normal blood pressure is. And then is it just a spike or is it maintained for some time? Because we all have blood pressure spikes for different reasons. So for autonomic dysreflexia, especially if it's coming at night, so there's probably nothing that's autonomic dysreflexia comes from something that is irritating the body below the level of injury. And it can be an irritant like they have an itch, but they don't feel the itch because of the lack of sensation. Or it might be something like if they're having sex, it can be a good irritation or it can be a bad irritation. So sometimes people overlook that there's good irritations as well. And so, figuring out what it is, the top three causes of autonomic dysreflexia that we call AD, first of all, could be some kind of bladder issue. So making sure that that catheter is flowing, or make sure that they haven't overfilled their bladder. Sometimes there can be a little stone that gets passed and kinks the catheter, but then you go to look at the catheter and you move the legs and the stone gets dislodged, so you never knew that it was there. There can be lots of irritations from the catheter. It could be clogged for any particular kind of reason. The second, or if you have intermittent catheterization, sometimes when you get into bed at night, you put the legs up, that fluid from that collects down in the feet from being dependent all day suddenly will or slowly will rush to the heart. And so that can cause dysreflexic because their bladder's full. But in the daytime, it wouldn't have been noticed because the edema is still down in the feet. So those are some bladder issues. Bowel issues could be an impaction, it could be a hemorrhoid, it could be anything that's going on in the bowel. And the third one is a skin irritation. Could just be that the sheets are wrinkled, or maybe her pajamas or nightgown has gotten kinked underneath her. That can trigger. So you have to make sure everything is smooth underneath the patient, and turning them is also important. So a lot of times people say, well, I'm on a pressure reduction mattress, so I can just lay on my back and sleep all night. But there is no pressure reducing mattress or cushion that can prevent pressure. They can reduce the risk greatly, but there's not one that's going to eliminate. You have to turn, you have to do the pressure releases, you have to do all those kinds of things. And then it can be anything else on the face of the earth that's, irritating. It can be a toenail that's ingrown. It can be an infection. It can be a little tiny, oh, I bumped my toe and didn't realize it. It can be just anything that can be irritating. It's surprising that some people have what's called silent AD that only occurs at night while people are sleeping. Well, it can occur during the daytime as well, but they discovered it while people were sleeping at night. And they were people that they didn't suspect had AD. They didn't have AD in the daytime, but they took the blood pressure for a totally different reason in the middle of the night. And they found that people were having silent AD. So it's good to have your own blood pressure cuff, know what your blood pressure is, and check for that. The same person has some external hemorrhoids. Is it safe to surgically remove? Well, the first treatment, again, we have a hierarchy for that. If the hemorrhoids are not too bad, if they've just developed, you can take a gloved, lubricated finger and reinsert the hemorrhoids into the rectum where the bowel will keep them moist. Hemorrhoids come from getting bowel tissue from getting too dry. So you can reinsert them into the rectum and use like something like preparation H, and slowly over time they will shrink down. Now, if they're really severe and you think they might need surgery, you will need to talk to your healthcare professional about that. They do not recommend people who have spinal cord injury that the surgery involve cutting the hemorrhoids, but rather the tying off procedure is the preferred one. Again, it's a surgical procedure, and we have to be very careful about those kinds of things. Any kinds of surgery can be very delicate for people who have spinal cord injury. Okay, so here's somebody who's having spasticity. It's not responding enough to baclofen and a list of medications that she's tried. She's asking about a baclofen pump, and she has some problems with her spine in the bony formation. And so would that be able to go in? Well, that you'd have to talk to your healthcare professional to see if they could get the tube from the baclofen pump through the bones to get it where it needs to go. So the baclofen pump is a pump that's placed in the abdomen. It's about the size of a pacemaker for the heart. It just goes under the skin, and it has to be refilled when the baclofen runs out in the pump. So you have to periodically have it refilled. Periodically, you have to have the battery changed, but it just sits under the skin in the abdomen, and then there's a little tiny tube that comes out of the pump, and it's wrapped around the body, inside the body, to the spine, and that tube has to go in the canal where the spinal cord is. So it depends on that bony formation if they'd be able to get that tube in there, because they have to go through the vertebrae to get that in there. And you might have to go a little bit higher and run the tube in a little bit lower in there. So, that would be up to the surgeon that places the pump. Now she's worried about obesity and would the pump be viable? I don't really see any reason why it would not, because you're just putting it under the skin and then wrapping it around. I see the real issue here being that of the bony formation might be the challenge here. But again, it's up to your healthcare provider, to make those determinations. So I don't really think that necessarily obesity might be an issue with the surgery and having the anesthesia. That could be a challenge there. But, again, talking to your healthcare professional would be the person that would make that decision. Interesting question about orgasms and sexual function here. So this lady said, can a woman have an orgasm after a spinal cord injury? And yes, people do. Women and men both face this challenge. And so people think, oh, I need to have an orgasm the way that I had an orgasm before I had a spinal cord injury. And more than likely, it's not going to be that way. But people have orgasms. It's just a different kind of sensation. And sometimes it will take your brain a little while to register what's going on. So it might not be, like this all out grandiose kind of orgasm, but it might be more subtle. But men and women both have to learn to read the signals in their brain of what's happening. There's techniques. We have a book about sexuality. There's all kinds of techniques that you can use to help stimulate orgasm or try to, recognize that orgasm. People overlook a lot of different stimulation techniques up above the level of the spinal cord injury. And she doesn't say what her level is, but there's a lot of different things that you can do to stimulate. So, like if you have a scar is very tender skin, and sometimes that can be very sexually stimulating. People forget about the ears are very erotic sexual organs. Sometimes people enjoy talking during sexual experience. There's a lot of give and take during the sexual experience with a partner. So listening to their sounds that they're making, their breathing can kind of help stimulate people into having a better sexual experience. So, the list goes on and on. So there is a book all about sexuality, and that would be a good thing to have. Now, again, it might be just a more subtle kind of feeling for you, but you can have sexual satisfaction. It just might be different than it was before your injury. There's a person that is in it's they're in the state of Florida, and uh, they're worried because they don't feel like they're being documented in the correct way according to a Florida registry. Well, now I certainly don't know. Each state has their own registry for spinal cord injury and brain injury. And it's like each state has a cancer registry, so they know the numbers of people and what's going on in their state. Now, there's not a registry for every single illness, like there's no asthma registry or anything like that, but there's some different illnesses where states have registries. And I didn't know this. The number was provided for the registry in Florida, so I had to look it up. And it sounds like it's a registry. And so they wanted all of their issues with their brain. They have a brain and a spinal cord injury, and they want all their issues listed. Well, registries just usually say you have brain injury, you have a spinal cord injury. They might list the level, but each state is completely different. So the fact that they're not listing all your issues with that registry, according to the computer what I was reading, that is only a registry if you have these issues. So with your if you have state Medicaid, or if you have Medicare disability, or if you have insurance, that's really the place where all your issues need to be noted. So I don't know that much about Florida. It would be better to talk to somebody from the state of Florida that could explain that registry to you. But it sounds like what you're talking about, they're not going to list, they don't list anybody's, all of their issues in there. They might list if you also had a fractured leg at the time of the accident. I know where I live, they'll put uh, uh, other issues that occurred, like, like that fractured leg, or if you had like an arm avulsion like that guy, but they won't list all the things like you have neurogenic bowel and bladder, or they don't they don't list all those things that go in the healthcare record.
They can also contact Disability Rights Florida, the protection
There
and
you go. Thank you,
advocacy.
Zach. That would be a good place. That would help you get through some some of that legal mumbo jumbo that's on the computer, which is, if you're not a legal person, it's kind of hard to figure out, like me. Okay, here's a person that fell off their ladder 2.5 years ago. They are T6 complete. They have no feeling, they have no abdominal muscles, and they would like to know, um, let's see, I'm having trouble clicking into this. Oh, they want to deal with long-term spasticity issues. Oh no, that's the wrong one. Oh, I lost the guy with the, I'm sorry, I lost your message here on my computer about, I'm sorry, could you write it back in again, or hit the Nurse Linda button on the Reeve Foundation? I'd be happy to answer you directly. I apologize. I hit the wrong key on something. Which vitamins and mineral supplements can be taken to help long-term spasticity? Spasticity is a very tricky thing to treat. It's different for everybody. There's no one treatment that works for everybody. There's no ABC, but we do again have a hierarchy. And some of the things you can do for spasticity is to move your legs gently. Again, if you move aggressively, like in that bowel program, you're going to make the spasticity worse. So very gentle movement of your legs helps. Um, Vitamins and supplements to help with long-term spasticity. You need to be very careful with what you're taking, because some people take a lot of vitamins and supplements, and they'll want to take like calcium, which can affect your heart, or they'll want to take other supplements that can affect other body functions. So people think a lot of vitamins and minerals, they're over the counter treatments. So, I can just go and take those ad lib, but you really can't, because whatever you ingest in your body is going to have an effect and a counter effect. So you need to be very cautious. So talk with your healthcare professional about what you should be taking. There are medications that can help with spasticity. A lot of people do not want to take them because they're oral medications, and it kind of gives you a little bit of a brain fog. And so people, they just don't want to do that. However, there's also Botox, which is an injection that has to be done periodically. It doesn't last forever. And that certainly helps a lot of spasticity. And a lot of people are not going for the total body effect of the oral medications, but they're moving to the Botox injections, which you might also be opposed to. And that's everybody's choice to choose what they want to do. But check with your healthcare professional before you start taking any vitamins and supplements, because they're probably not going to have the effect on the spasticity that you're looking for, because this is such a bigger problem, and they're going to affect your whole body too as well. They're not just going to go to the place where the spasticity is occurring, like if it's in your legs, they're going to affect your whole body as well. There's a question about wheelchair cushions, and is there one better than Rojo for preventing skin breakdown? Well, as I was saying, with the cushion underneath a person, while the pressure reducing cushions that's underneath your body when you're sleeping, you also have one in your chair. Rojo is a very good brand. There are other brands that are also very good. The best pressure reducing cushion for any person is the one that matches their needs. So not every cushion works the same for every person. Now, if you're a very heavy person, sometimes people will say, well, I've got enough fat, so I've got enough cushion. No, fat collapses under the weight of the body. So fat makes more pressure injury. But also, if you're underweight and you don't have really uh, uh, thick muscles, some good beefy muscles, if you're really underweight, those people are at a higher risk for pressure injury as well. So you have to pick out the cushion that's best for you. Again, some people will be able to use a medical grade foam cushion, which the cells of the foam are different. You cannot go to the craft store and get a foam cushion. You have to get a medical grade because they're closed cells. So they keep air inside the cells. Where if you go to the craft store or a couch cushion, and people say, well, I'm sitting on a couch cushion, I'm sitting on the airplane seat and it's cushioned. But the foam in there is not closed cells. So the foam just collapses and makes more pressure. So that's an issue. So you have to get medical grade, and when you move to any other kind of seating area, you have to sit on the medical grade cushion. Some people will do foam, some people do gel filled, some people have a water-based films cushion, some people have an air cushion that they adjust for their body weight, which is good for people on extremes of the weight spectrum. So there's all kinds of things, but the only thing that's really going to stop a pressure injury from happening is doing those pressure releases. As sad as I am to say that, that is going to be the issue. I know some people get a cushion and they never do any pressure releases and they go for years and years. And guess what? Aging comes to us all, and all of a sudden they have pressure releases. So these are all things that we have to think about as well. So work with your therapist to find the cushion that's the best one for you. That's the best cushion. Can you provide tips on safely building my shoulder strength to participate in transfers from chair to bed using slider board versus a Hoyer lift? And yes, you can do a lot of exercises. You can look up shoulder exercises after spinal cord injury. I'm sure we have exercise pages that are on the Reeve website. If you think back to your rehabilitation, doing push-ups helps build your shoulders. If you have a mechanical bike to crank or doing a little bit of weight lifting. Now, the Hoyer lift, if you have one, that's great because again, the arms are built like the legs, but the arms aren't as strong as the legs. So the legs are built anatomically to hold the weight of the body. The arms, not so much. They can become strong and they can do it, but people have a lot of trouble with their shoulders, especially later in life, or if they're moving their body for long periods of time. So if you want to do that, and I admire your independence, that's great. You should build up your shoulders to get maximum benefit from being able to do what you need to do. But when you're at home, you can't take your Hoyer lift with you everywhere, I realize. So when you're at home, use your Hoyer lift. And then if you need to transfer outside the home, that would be the opportunity to do that. So I admire your gumption for wanting to have to do that. Excuse me. Any tips to help reduce the wide swings I experience in my blood pressure? And again, that's a medical issue. You're going to have to find out what's causing the wide swings. If you're having high blood pressure, which is 20 to 40 degrees above your normal blood pressure, your normal average. We all have fluctuations. You're talking about really wide fluctuations. You could be having autonomic dysreflexia. So monitor your blood pressure, talk to your healthcare professional to make sure that you are not having that silent kind of AD that you're only seeing with um, blood pressure and not necessarily with your activity. 15 millimeters of blood pressure for children is that over the range. Some questions that have been typed in. Have you heard of Fosamax for bone density? Yes, a lot of people take that. Again, there's several drugs that you can take for um, bone density. So check into that. There's a foundation would like to answer this. So go ahead, Zach. Oh, I guess I misread that. Okay. So I think we will see something about bone density coming up here shortly. The robotic arms that connect wheelchairs and apparently allow quadriplegics to pick up things. There are all kinds of devices that can be used to help people. Again, you will have to speak with your healthcare professional to find the one that's right for you. They will have to write a letter of medical necessity. There are some robotic arms that you wear, actually devices that you actually wear to put on your arm that connect to your nerves that are working up higher in your shoulder. And so that will give you some hand function. They're very advanced. Of course, I think it's fabulous. But they are quite hard to get. But if you keep working with your insurance, if you get the medical necessity, and the first time, let's face it, you're going to be rejected. So you have to appeal and you have to appeal and you have to appeal, but keep at it. And people do have success with these things, but it comes with a little work on your end. My husband is 3 weeks after spinal cord injury, T4. Although he behaves like a complete injury, how important is it to move patients' legs after injury? Rehabilitation hospital does not do that. I want to know how much I should do it every day to keep his ligaments flexible. Actually, it should be done every morning and every night. So that's important. Let them teach you how to do it so that you know how much pressure to apply, how you'll be able to recognize if a joint becomes contractured. And yes, a lot of care falls to family members, but it's helpful to keep everything in functioning, the muscles functioning, the lubricants, keeping those joints lubricated, the ligaments flexible. All of this is very good, and it also is providing stimulation to the nerves and muscles below the level of injury. Now, while you do that, have him look at his legs and have him think about when you're moving his toes back and forth, when you're moving his ankle up and down, when you're moving his ankle around, have him think my right ankle's moving around, my foot's moving up and down, my knee is being pulled up to my chest, because hopefully the thought in the brain will go down to his spinal cord where the injury is. The movement that you are providing will go up to the spinal cord, and hopefully you'll be able to make some kind of connection. Now, is people don't know how often this happens. This is not like you do this for 20 days and all of a sudden it's better. It's an ongoing process. Some people actually will find that they'll have a connection, their big toe will start moving. These things happen all the time, and people will say, oh, well, that's just an oddity. No, they've made a connection. So you want to capitalize on that connection and keep going, just keep going. People haven't really studied this, so nobody knows how long it will take. Some people find out right away and they start getting things, some return back. Some people it takes years and years. So just keep doing it. We cannot keep just writing people off because, oh, well, this didn't happen. Look at he split. This is a long-term process. How's the treatment center certified to handle SEI injuries? Is there a website that lists treatment centers in the USA? Well, there are major centers in the USA Craig Hospital in Denver and Shepherd Center in Atlanta are the two big that are devoted to spinal cord injury and brain injury. But there are other large rehabilitation centers. Like I mentioned, some of these programs and oh, I didn't mention the Miami, every state has a spinal cord injury center in it. So, you just have to look for those and talk to your healthcare professional. We all know who they are. So people in the community don't know who they are, but talk to your healthcare professional and they will tell you the best place that's closest to home. Is electrical stimulation available in the New York or Philadelphia area? It's available everywhere. Can you recommend a facility? Well, in New York City and between New York City and Philadelphia, there are a lot of very good rehabilitation centers. So again, talk to your healthcare professional because yes, it's available everywhere in the United States. In the rural areas, not so much, but you can find it especially in high populated areas. And we're coming up to the end here, so I have to zip through these last ones. A spinal surgeon identified arthritis, filling in damaged nerve canals. Has this caused me pain? Okay. Yes, arthritis can affect the spinal cord injury, especially as the bones become shapen differently. And so a management doctor suggested an epidural. It's very expensive and did not help. Did you have any? Um, oh, okay. So I think Zach is going to type you an answer there. So yes, there are different treatments that can be done for arthritis. There's a variety of treatments that can be done to help relieve that pressure. So talk to your doctor. You might want to talk to a neurosurgeon to get some of those treatments. The best foods to avoid constipation are foods high in fiber. So eating raw vegetables, that can be very helpful. We talked about spasticity. Um, Oh, the guy from Florida with the break, and I lost his question. Thank you so much. I'm so embarrassed. Will I ever be able to get back my abdominal muscles on? I remember reading this before, and my mind kind of goes blank after I'm on camera, like most people. But will I be able to get back my abdominal muscles? It's quite possible that you could. I would try some electrical stimulation. Will you be able to control those on your own at T6? You might be able to strengthen them, especially at the zone of transition. But I think you'll find with some electrical stimulation that you'll be able to um, strengthen your abdominal muscles. Now, if you will be able to control those on your own, I don't know. But with some of this electrical stimulation things that are coming out, if you look at the Onward company, if you look at the Spinex company, they are going to be coming out with some products very soon, and that will help you be able to control your abdominals, which will help with the bowel and bladder. And they will help with all muscle stimulation. So, and they're having very good success with them. They're in clinical trials, but they're soon to come out of clinical trials. And then transanal irrigation for bowel management. Yes, I've talked about this several times, and some people love it, some people don't like it. It's it's a product that you have to use. It has a lot of equipment with it, and so people have a hard time learning to use it. But you can call the Peristeen company, and they have nurses that will walk you through it and get you able to use it. If you want to travel or you're going someplace outside your home, it's a lot to take with you. And so, but some people love it, some people don't like it so much. So I see you're using Clolay, Senna, and Dig-Stim. You might want to try the enemies before you go to the Peristeen. It's a matter of personal preference. So a person has some disc causing stenosis that's making some problems in sensation and the left and right legs. Does the nerve root recover if pressure is removed? It depends. It depends. If the if the pressure on the nerve root is at the end of we're talking L5, so those can be nerves that are coming out of the spinal cord. So those are peripheral nerves. Peripheral nerves can have surgery, um, and they can have things manipulated. Peripheral nerves will recover at rate of 1 inch per month. Now, if it's in the central nervous system, actually in the spinal cord at L5, then that's a different situation. If it hasn't been too long and the pressure's taking off, you should have some recovery. It depends on how much damage has been done and how long the damage has been there. So you'll have to talk to your neurosurgeon about that. But is there a possibility? There is a possibility. How much time will it to recover? Again, if it's in the peripheral nerve, it's 1 inch per month. So that's what it is. So, okay, we're way past our time, but I thank you so much. I hope I've answered everybody's question. Andy, thank you so much for asking your question again. I just felt really horrible about losing your question, but hey, I'm not a computer guru, so it happens to us all. So thank you so much for joining me. I would like to remind you that I will be in May 4th in the New York, New Jersey Abilities Expo on Saturday at 1 o'clock. So if you're in New Jersey or New York, come to the expo. They're really fabulous. And you can look for me at the Reeve booth, but I'll also be doing a presentation at 1 o'clock, and I'll be looking for you. So thank you so much for joining us today.